Welcome to the deep dive. Today we're tackling a condition called Discitis. You might not hear about it every day, but it's definitely one to know. We're essentially doing a focused revision session here.
Exactly. We've got your revision notes laid out, and the plan is to pull out the absolute must-know info, make it really clear, maybe even memorable for recall.
Think of this as your high-yield pass on Discitis. We'll cover it all, what it is, how it happens, how you spot it, treat it, and what the outlook is. Right, let's jump in. What exactly is Discitis?
So simply put, Discitis means there's inflammation and usually an infection in the intervertebral discs, those cushiony pads between your spinal bones.
It's typically bacterial.
Most often bacterial, yeah, sometimes fungal.
Okay, and this isn't just like a simple back strain. My notes mention some quite serious potential problems.
That's absolutely right. You really need to be aware of the risk of major complications. Things like sepsis, that's a really dangerous body-wide reaction to infection or an epidural abscess.
An abscess near the spine. That sounds bad.
It is. It's a collection of pus that can press on the spinal cord or nerves.
Yeah.
And you'll also probably hear the term Spondylodiscitis thrown around.
Spondylodiscitis. Okay, what does that mean? Is it different?
It's related. Think spondylo for the vertebrae, the bones. So spondylodiscitis just means the infection isn't only in the disc, it's spread to the adjacent spinal bones too. It's a bit more extensive.
Right. Involves the bones as well. Okay, that makes sense. So we know what it is.
Yeah.
What causes it? What's the etiology?
The main player, the most common cause, is bacteria. And the specific one you'll see again and again is Staphylococcus aureus.
Ah, good old Staph aureus.
Yep. Less often you might see fungal infections or even viral ones, though they're rarer. And like we just said, if it's spondylodiscitis, remember those vertebrae are involved too.
Okay, Staph aureus is the usual suspect. Now, who's more likely to get this? Are there specific risk factors we should look out for?
Yeah, there definitely are. A big one is having a weakened immune system for any reason. Makes it harder to fight off bugs, Also, having had recent spinal surgery can sometimes provide a route for infection to get in.
Right, an entry point.
Exactly. Another one is intravenous drug use. And underlying medical conditions, things like diabetes or cancer, can also, unfortunately, make someone more susceptible.
Okay, so weakened immunity, maybe recent surgery, IV drug use, diabetes, cancer, those are key vulnerabilities. Let's talk about how it actually develops, the pathophysiology. How does the infection get into the disc and cause trouble?
So these microorganisms, usually bacteria, need to get into the disc somehow. Sometimes it's from an infection nearby, like in the bone, but probably more commonly it spreads through the bloodstream. We call that Haematogenous spread.
Haematogenous, meaning it travels in the blood.
Precisely. An infection starts somewhere else in the body, maybe the skin or urinary tract, and the bacteria get into the blood and travel, eventually settling in the disc space.
Like seeds carried by a river.
That's a good analogy. And once they land in the disc, they start to multiply, causing the infection and the inflammation, which then damages the disc tissue itself.
Does it matter where in the spine this happens?
It does seem to have a preference. It's most common in the lumbar spine, your lower back. A bit less common in the cervical spine, the neck. And it's actually pretty rare in the thoracic spine, the mid-back.
So mostly lower back, then neck, rarely the middle.
Yeah, you could think low, then high, rarely middle, something like that. Another point is that finding the original source of that infection, the one that seeded the disc, can often be really tricky. It might even be gone by the time the Discitis shows up. Oh, and an interesting nuance, while we said recent spinal surgery in general is a risk factor, Discitis is actually considered quite rare, specifically after disc space surgery itself.
Okay, that's a useful distinction. Now, back pain is so common. If someone comes in with it, how do you differentiate? What else could it be besides Discitis? What's on the differential diagnosis list?
That's crucial, because Discitis is rare. You absolutely have to think about the more common stuff first. Things like degenerative disc disease, just wear and tear, herniated disc, a slipped disc. Even things like spinal tumors or spinal fractures need to be considered.
Rule out the common things first. Makes sense. How common is Discitis then? You said rare, but what does that mean in terms of numbers, maybe in the UK?
Yeah, it's definitely classed as rare here. Estimates are roughly around 2 to 5 cases per 100,000 people per year. So not something you'll see every week.
Okay, definitely uncommon. And who tends to get it? Is there a typical patient profile?
Well, it can affect anyone, but statistically it's seen a bit more often in males, typically around their 50s. But And this is important, children can get discitis too, so it's not exclusively an adult thing.
Right. So middle-aged men, most common, but don't forget kids. Okay. So if someone does have it, what does it look like? What are the signs and symptoms of clinical presentation?
The core symptoms are usually pretty significant back pain, often quite localized over the affected disc. Spinal stiffness is common too, and just limited movement, finding it hard to bend or twist.
And do they feel generally unwell?
Often, yes. You might see systemic symptoms like fever, maybe fatigue. And the really worrying thing is if neurological issues develop weakness, numbness, tingling in the legs, for example, that suggests the infection might be affecting the nerves.
That sounds like a red flag.
Absolutely. General signs like pyrexia, that's fever, or rigors, which are those intense shaking chills, are significant. And of course, signs of sepsis mean it's very serious. Neurologically, any change in lower limb power, sensation, or bowel bladder function is a major concern, especially if you suspect an epidural abscess is forming.
And diagnosis can be tricky because it's rare.
Exactly, and the onset can be insidious, meaning it creeps up slowly.
Yeah.
You might find very specific point tenderness when you press on the spine. The pain typically worsens with movement,
Yeah.
and their range of motion will be restricted. Keep an eye out, too, for associated things like that fever we mentioned, or unexplained weight loss.
Any difference depending on where in the spine it is?
Well, neurological deficits are perhaps a bit more likely if the infection is higher up in the cervical spine, just because of the anatomy and how close everything is packed together there.
Okay, so severe back pain, stiffness, maybe fever, weight loss, and any neurological signs, those should definitely make you think, how do we confirm it? What investigations do we use?
Right, investigations. We'll typically start with blood tests, a full blood count, and definitely inflammatory markers like ESR and CRP. These are usually elevated in infection.
ESR and CRP are key.
Yeah, they're very helpful, both for diagnosis and monitoring treatment. But for imaging, the real gold standard is an MRI scan.
Why?
It's just the most sensitive test for looking at the discs themselves and the surrounding soft tissues, like detecting inflammation or an abscess. A CT scan can also be useful, especially for looking at the bony structures in detail. But MRI is really king here.
MRI is king. Got it. Is that enough for diagnosis?
Often the MRI picture plus the clinical signs are very suggestive. But for a definitive diagnosis, and especially to know what bug we're dealing with, a disc biopsy is usually needed.
Taking a sample of the disc.
Exactly. You take a small tissue sample, often guided by CT, and send it to the lab for culture. That tells you if it's bacterial or fungal and exactly which one, so you can target the antibiotics correctly.
Makes sense. Are there any other tests that might be done?
Sometimes, yeah. An echocardiogram, an ultrasound of the heart might be done to check for endocarditis, an infection on the heart valves because the bacteria can sometimes spread from there, or vice versa. We also track those ESR and CRP levels regularly to see if the treatment's working. They should come down. And it's worth remembering, the white blood cell count, which you often think of with infection, might actually be normal in Discitis. So don't be falsely reassured if it is. We might also culture blood, sputum, urine, trying to find that original source of infection if it's not obvious.
What about plain X-rays? Do they show anything?
They're much less sensitive, especially early on. Later, you might see things like narrowing of the disc space or some irregularities on the edges of the vertebrae next to the disc. We call those end plate changes. Maybe some calcification. Nuclear medicine scans can sometimes help too. But again, MRI is way better for showing the actual discitis.
So biopsy is key for identifying the organism.
Yes, CT-guided or sometimes an open biopsy confirms it and lets you tailor the treatment. Sometimes during an open biopsy, they might also do a surgical debridement, basically cleaning out the infected material.
Right. So once we have the diagnosis, maybe even the specific bug identified, how do we treat discitis? What's the management plan?
The cornerstone of treatment is medication, usually intravenous antibiotics if it's bacterial, or antifungals if it's fungal. And this is typically for quite a long time.
How long are we talking?
Often 6 to 8 weeks of 5E therapy is the standard starting point. The choice of drug, of course, depends entirely on those culture results from the biopsy.
Okay, long course of 5E antibiotics. What else?
Pain management is crucial. Obviously, these patients are often in a lot of pain. And spinal immobilization is really important too.
Immobilization, like a brace.
Exactly. Often a spinal brace is used to reduce movement, decrease pain, and hopefully allow the spine to stabilize and heal. Sometimes there might be a period of bed rest initially, maybe for a couple of weeks, then into a brace for potentially 3 to 6 months. And analgesia, painkillers, are given as needed.
And when would surgery come into the picture?
Surgery is usually reserved for specific situations. If there are significant neurological problems, weakness, loss of sensation, bladder issues, if the spine becomes unstable or develops a deformity like a significant curve, or if the infection just isn't getting better despite appropriate antibiotic treatment. Failure of medical management, essentially.
Got it. Antibiotics, pain relief, bracing, and surgery for the more severe cases. What's the typical outcome then? What's the prognosis?
Generally speaking, the prognosis is actually pretty good if it's diagnosed reasonably early and treated properly with the right antibiotics for long enough.
It's good to hear.
It is. But recovery can definitely take time. It's often a slow process. And some people, unfortunately, might be left with chronic back pain even after the infection is cleared. Recurrent infections are also a possibility, though less common.
Any risk of permanent problems?
Yes, a small percentage of patients might have some permanent neurological damage, like persistent weakness or numbness. And there's always that small risk of the infection spreading elsewhere. The overall mortality rate, the risk of dying from Discitis itself, is relatively low, estimated around 2%.
Okay, generally good, but recovery takes time and some long-term issues are possible. What are the main complications we need to worry about during or after treatment?
The big ones we sort of touched on. Developing a spinal abscess, that collection pus, is a major concern because it can compress the spinal cord. Spinal instability is another. The infection can damage the structures that hold the spine stable.
And the neurological deficits we mentioned.
Yes, neurological deficits and chronic pain are significant potential complications. And as I said, the risk of the infection coming back, a recurrent infection, is also there.
So it really highlights the need for getting onto it quickly.
Absolutely. Early diagnosis and starting the right treatment promptly are really the keys to minimizing the chances of these serious complications developing.
Okay, let's do a quick wrap-up then. What are the absolute key takeaways for Discitis?
Right. Discitis. It's an infection, usually bacterial like Staph aureus, affecting the spinal discs. Think severe back pain, stiffness, maybe fever. Diagnosis hinges on clinical suspicion and, critically, an MRI. A biopsy is often needed to pinpoint the exact cause.
And treatment.
Treatment is primarily long-term IV antibiotics guided by culture results, plus pain control and spinal immobilization, often with a brace. Surgery is for complications like nerve compression or instability. Prognosis is generally good with timely treatment, but recovery can be lengthy, and complications like abscesses or chronic pain can occur.
Great summary, and maybe a final thought for everyone listening. Given how common back pain is, what subtle combination of signs or symptoms might just trigger that thought, hang on, could this be something more serious like Discitis and push you towards investigating further, something to mull over?
And if you want more detailed revision materials on Discitis or other conditions, head over to passthemMSRA.com.
Yes, and for loads of excellent free resources to help with your MSRA prep, definitely check out freemsra.com. Thanks for joining us for this deep dive.